Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features a discussion between James Davis, PharmD and board-certified oncology pharmacist from the MUSC Hollings Cancer Center in Charleston, South Carolina, and Victoria Nachar, PharmD and board-certified oncology pharmacist from the University of Michigan Rogel Cancer Center in Ann Arbor, Michigan. They will bring us up to date on key data from recent presentations at the American Society of Clinical Oncology and European Hematology Association annual meetings related to the use of BTK inhibitors for the care of patients with CLL. This episode is part of a larger educational program titled Optimizing BTK Inhibitor Therapy in CLL, Updates and Strategies for Oncology Pharmacists. For more information on Drs. Davis and Nachar, along with a link to the larger educational program, please visit the show notes for this episode. Now let's get started and hear what our presenters' thoughts are on recent updates for BTK inhibitors in CLL.
We're here today to talk about updates for BTK inhibitors in CLL, some exciting updates from the recent ASCO and EHA trial. I think it's good, though, if we give the audience a little lay of the land briefly of where we are with BTK inhibitors before we start. We see use of covalent BTK inhibitors starting first with ibrutinib and now second-generation BTK inhibitors, acalabrutinib and zanubrutinib. We know they maintain efficacy compared to ibrutinib and reduce incidence of AFib, bleeding, and hypertension. And so I think covalent BTK inhibitors are really a mainstay for both frontline and relapse refractory CLL, with preference to those second-generation covalent BTK inhibitors. Therapy decision really is balanced, I think, against fixed duration-based regimens, which include our BCL2 antagonist venetoclax, as well as the NCCN update to include a new regimen, acalabrutinib with venetoclax, which is fixed duration based on the Amplify trial. And so therapy decisions there are really just based on patient preference, comorbidities, drug interactions, etc., where you have your covalent BTK inhibitors that are given continuously, indefinitely, until disease progression or intolerance, or a fixed duration where patients can take a treatment break. What about in the relapse setting, James? We have a new class of BTK inhibitors that we're interested in.
Yeah, so we've got a new class. We have one drug on the market, pirtobrutinib, which is a non-covalent BTK inhibitor, can bounce in and out of that BTK binding site, which is shown in the BRUIN study that we talked about in our original programs, showed efficacy in patients with the BTK 481 mutation and also efficacy in patients that had prior covalent BTK inhibitors and patients that had prior venetoclax-based regimens. And so we've got pirtobrutinib as an option now, and we'll talk about a recent publication in a little bit that included pirtobrutinib. I did want to call out a couple of unmet needs that maybe will transition us into our new data, but we're really seeing a lot of new data involving measurable residual disease or minimal residual disease, aka MRD. And so we'll talk about the FLAIR trial and MRD-guided therapy. Historically, in the original covalent BTK inhibitor trials, there was not a lot of patients included that had a 17p or TP53 mutation. And so those are high-risk mutations. So we'll talk about the SEQUOIA 5-year update, which included patients with 17p. And then we'll talk about the newest BRUIN 321 trial that also included those high-risk patients.
I think really exciting out of EHA was an update to the previously published UK FLAIR trial. So to review, this was a prospective phase 3 randomized trial in which patients were randomized to an MRD-guided ibrutinib and venetoclax regimen, which was intended to be fixed duration, versus ibrutinib alone, which was continued daily until disease progression, or another arm they could be randomized to was FCR, our historical chemoimmunotherapy. Patients with deletion 17p, of course, were not included in this trial because one of the control arms was chemotherapy. We know their outcomes are suboptimal. In the experimental arm, so the MRD-guided ibrutinib venetoclax arm, the stopping rules were based off of a patient obtaining an undetectable MRD. So essentially, patients were able to stop the combination therapy at twice the time it took them to achieve an undetectable MRD. The minimum was 2 years of treatment with a maximum of 6 years. And we saw that about 40-ish% of patients stopped treatment at 2 years in the combination arm, another 10-15% at 3 to 5 years. So we see about 40% of patients that needed all 6 years of therapy with the ibrutinib and venetoclax. And previously, we saw that the combination-based regimen, ibrutinib with venetoclax, had a significant improvement in the rate of undetectable MRD as well as progression-free survival, which were the two primary endpoints or key endpoints that the study was powered for. And so at EHA, they actually reported the overall survival endpoint. The study wasn't actually powered for this, but this was a key secondary endpoint, and they reported a significant improvement in survival for ibrutinib with venetoclax versus ibrutinib alone. It was about 91% with ibrutinib alone versus 96% with ibrutinib and venetoclax at 5 years. But there was a higher incidence of sudden cardiac death as well with a continuous ibrutinib. And so I think this is exciting abstract and exciting data to see because this is the first study that has really shown, right, an overall survival benefit with a combination ibrutinib venetoclax or BTK inhibitor venetoclax-based approach versus a single agent BTK inhibitor. And it's just showing really, I think, exceptional PFS and OS. I would really like to see more granular details on the reasons that patients died in the trial to see if they were actually related to CLL or ibrutinib-related toxicities. I think that will really help me to fully interpret these overall survival results. But I do think this also shows that just looking at a single agent BTK inhibitor continuously, it may not be the best approach. While we can get durable PFS, clearly there's this increased risk of cardiac death. Of course, this is with ibrutinib, and we prefer second-generation covalent BTK inhibitors now. So it's really hard, I think, to interpret all of the results in the context of how we're using these agents currently for both frontline and relapsed CLL. But I think a really exciting trial just to see this overall survival benefit. And then going back to the duration of therapy, minimum of 2 years, but up to 6 years, in which we see like a good percentage of patients needed 3, 4, 5 years of therapy, if not more, in the study. And I think it's just hard to balance this with venetoclax obinutuzumab-based regimen, which we know is 12 months, and then patients stop, and we're seeing durable PFS there. James, what do you think about this trial?
I was surprised that the overall survival difference, though it's not powered, came at 5 years. And a lot of times the patients live a long time. So at 5 years to see this statistical difference was a little bit surprising to me. I really feel good about MRD guided therapy. I would love to have patients be able to stop or have fixed duration treatments based on MRD. I think it's at this point, it's hard to say that this FLAIR trial is going to benefit patients more than like a fixed duration venetoclax obinutuzumab, like you alluded to. Outcomes of the CLL data, the CLL13 data is so good. I don't know if I would put someone on this over OB-Ven unless they don't have access to an infusion center that's local to their house or something like that where they need an all-oral regimen.
We have the Amplify trial, which they could just do a acalabrutinib with venetoclax, which is 14 months, whereas this is MRD guided. It's minimum of 2 years at least, with most needing more. So I agree with you. I'm interested and intrigued by MRD guided approaches, but with the fixed duration regimens we have now, we can stop regardless of a patient obtaining an undetectable MRD state.
Yeah, I agree. It's like the study is, this is an update, but it's like we don't use ibrutinib anymore. So how relevant is it to? I think it's good to have OS data. I wish it was with another BTK inhibitor maybe. It'll be exciting to see Amplify longer term data too.
As well as the ongoing MAGIC trial, which is acalabrutinib with venetoclax versus venetoclax plus obinutuzumab.
Yeah, there's a number of those MRD trials coming down the pipe.
Yeah. Transitioning to another covalent BTK inhibitor trial that you alluded to that we saw data for at the ASCO meeting was a 5-year update of the SEQUOIA trial. And you touched on one key group of patients that we're particularly worried about in CLL are very high-risk patients that have poor prognosis, and those are our P53 mutated or patients with deletion 17p. We know, again, these patients were excluded from that FLAIR trial we just talked about because of the chemoimmunotherapy arm. We know that patients with deletion 17p have very poor progression-free survival with chemoimmunotherapy. So we have moved towards using novel agents like covalent BTK inhibitors in this patient population. And we've seen small numbers and small pockets of patients with these high-risk mutations in these covalent BTK inhibitor trials showing pretty durable progression-free survival, 4, 5, 6 years or even longer, which is hugely improved from the chemoimmunotherapy era in these patients. But what we really never had is a very large cohort of patients with these mutations to say what should be the right approach in a patient with a deletion 17p. And so the SEQUOIA trial was a multi-arm trial. We're going to be focusing on the arm C, which is the 5-year readout of zanubrutinib for treatment-naive CLL in patients with deletion 17p exclusively. They had over 100 patients, which is by far the largest cohort of patients with deletion 17p treated with a covalent BTK inhibitor. And what they showed was that the median progression-free survival in these patients was not reached at 5 years. It was about 72% at the 60-month mark, and overall survival about 85%. And I don't know if this changes our treatment approach. I think we are concerned about using fixed duration regimens in these patients because in the CLL14 trial with venetoclax obinutuzumab, the PFS was a little bit over 4 years for fixed duration in patients with deletion 17p. And what we're seeing with single agent zanubrutinib in the SEQUOIA trial is much longer progression-free survival. So I think for me, this kind of just solidifies my practice to give a covalent BTK inhibitor if I can to patients with deletion 17p, maybe try to shy away from a fixed duration regimen. James, what is your practice for these patients?
Yeah, I think this is not practice changing, but definitely practice confirming. It gives us good data to really confirm what we're doing now, putting patients on zanubrutinib up front, those patients with 17p, that TP53 mutation. And now we have data to tell these kind of patients roundabout how long you will go without progressing or good overall survival data. So I think it's really practice confirming and really solidifies what we're doing and gives us that patient education data to talk with them about.
Yeah.
So Victoria, were there any key safety updates within the SEQUOIA data that were concerning, or is this more confirming what we already knew about zanubrutinib?
I think for me, it just confirmed what we already know. I don't think there was any increased safety concerns. We see there is the cardiac bleeding, hypertension with zanubrutinib. It didn't seem what was reported here is much different than what we previously saw in the literature. So in the relapse setting, give us the BRUIN 321 trial.
All right, so we know pirtobrutinib is an option in patients that have relapsed or refractory CLL based on the original BRUIN trial, which was a phase 1/2 trial that had 317 patients. The newest trial is the BRUIN 321 trial, which is the phase 3 version, which compared pirtobrutinib to physician's choice of either idelalisib plus rituximab or bendamustine plus rituximab. So you've got a PI3K inhibitor plus rituximab or traditional chemoimmunotherapy. This included all types of patients. About half of patients had prior venetoclax-based therapy. This was an international study that included Europe, Asia, US, Australia. About half of patients had a 17p deletion. Over a third of patients had the BTK 481 mutation. So we've got all different types of patients here. They also allowed crossover, which is really nice. I know we really like to see crossover. If the first randomization doesn't work or they progress on that, then they're able to cross over to the study arm, in this case, pirtobrutinib. And what they found at a median follow-up of 17.2 months was PFS and independent review committee based progression-free survival difference of 14 months versus 8.7 months, favoring the pirtobrutinib arm. That was statistically significant. At 18 months, the overall survival rate was about 3% difference. That was not statistically significant, but again, this is only about a year and a half of follow-up. Interestingly, the median time to next treatment was almost double, 24 months for pirtobrutinib and not 10.9 months for the investigator's choice options. About 76% of patients were able to cross over. And then when we get to safety, infections were the biggest concern, which is similar to what we know about pirtobrutinib and other BTKs. Typically, those infections are respiratory-related pneumonias or COVID-19. Bleeding and AFib and hypertension were uncommon, which is good as these newer BTKs, as we've seen in the past. So I think we have confirmation here that pirtobrutinib beats a PI3K inhibitor plus rituximab, which is probably not a standard of care option these days, but bendamustine and rituximab may be a choice that some physicians choose. So I think pirtobrutinib here wins out. What are your thoughts?
Yeah, I agree. I don't think this is practice changing, but more practice solidifying to just show the role of pirtobrutinib in patients who have received a prior covalent BTK inhibitor and venetoclax-based regimen, to show the efficacy compared to more historic treatment options in this setting. I guess my question for you is, you talked a little bit about maybe PI3 kinase inhibitors are not used in the relapse setting, maybe not a lot of chemoimmunotherapy is used. If you were to design the trial now, what would you want that control arm to be?
That's a good question. At this point, I don't know if I mentioned, but all of the patients in this trial had 100% of the patients had a prior covalent BTK. So that's important to know. So you can't use that in a control arm if I'm designing a trial. Ven-based therapy is obviously an option, but 50% of the patients had venetoclax-based therapy. So you could have that as an arm. After that, we're really, at this point, we're using pirtobrutinib. So my other options are maybe chemoimmunotherapy, maybe something like an allogeneic transplant or a CAR T-cell therapy. So maybe that could be an arm if we're getting really creative. In practice now, I think after Ven-based and covalent BTK, we're using pirtobrutinib, and we know this PFS benefit in this trial is 14 months. We're using pirtobrutinib as a bridge to get someone under control to see what's next. We know it's not going to last for 5 or 6 or 7 years like the covalents are up front. And so whether that next step is an allo transplant or CAR T-cell therapy is really, I think, the question.
I totally agree with you. I think it would be nice to see how pirtobrutinib compares to a venetoclax-based fixed duration regimen after covalent BTK inhibitor exposure, or see how pirtobrutinib compares to CAR T. I think overall, again, it solidifies the practice to use it, but I will say I'm a little bit disappointed in the median PFS of only a little bit over a year. I expected or wanted longer out of it, but it's still better, right, than other options we have. They did also present at EHA their patient-reported outcomes from this BRUIN 321 trial. What do you think are key takeaways from that?
So I'm a fan of patient-reported outcomes. I think that it should be mandated that all trials report patient-reported outcomes. And they found here that patients reported improvement in CLL-related symptoms, physical function, and fatigue, favoring the pirtobrutinib arm versus the chemoimmunotherapy, which is not surprising. In the patients that I've used pirtobrutinib, most describe it as a placebo. It's like they don't know that they're taking anything. And if you've ever given chemoimmunotherapy, BR, for instance, BR is fairly well tolerated in like the chemo world, but patients know they're getting chemo. So the patient-reported outcomes aren't surprising to me, but I'm glad that EHA accepted this abstract and that it's out there.
I agree. We love to see the patient perspective too, because like you said, this is a chronic condition. We want to make sure that not only are we improving their outcomes, but we're improving how well they live as well. We had 3 large abstracts from the EHA and ASCO conferences. What are your overall conclusions for the BTK inhibitors in CLL, where we currently sit?
I think we have confirmation that we're comfortable using covalent BTK inhibitors in 17p deleted patients. We have data to tell them, to give them like time if they ask, time to progression, things like that. I'm excited about MRD coming down the line in the next 5 years. Probably we'll have a lot more mature data from some of these MRD related trials. And frankly, pirtobrutinib got approved patients that are young with CLL after venetoclax-based therapy and covalent BTKs. We really didn't have much. And in the last several years, now we've got pirtobrutinib and RT, and hopefully they have an allo donor for an allo. It's exciting, some of these things coming down the line, and we're still early in the data phase. So combinations, I think, will be a thing in the future, and MRD and CLL is changing rapidly.
Yeah, I completely agree with you. And I think, too, thinking future forward, there was a little bit of data at ASCO on a new emerging class of drugs called the BTK degraders, showing potential exciting efficacy in patients who have seen our covalent or even non-covalent BTK inhibitors to hopefully give patients another subsequent line of therapy. More data, I think, to come with CAR T. Outcomes right now don't look great, but if we use it earlier, maybe they would look better. Still a lot to learn there, as well as how the bispecific antibodies will shake out, the CD20 targeting bispecific antibodies in CLL. So a lot in the pipeline, but a lot of exciting updates and things that really just, I think, solidified practice and made us feel really good about the way we're managing patients in the current era at ASCO and EHA this year.
Thank you, Drs. Davis and Nachar, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Optimizing BTK Inhibitor Therapy in CLL, Updates and Strategies for Oncology Pharmacists, please click on the link in the show notes. And be sure to check back soon for more new CCO Oncology podcast episodes. As always, thanks for listening.